So good evening, everyone. I'm Nomer Budu. I'm the membership manager at Cambridge University Hospitals. Thank you so much for joining us this evening for an interesting and insightful lecture on the menopause transition. So without further ado, I'll now hand over to Dr. Helena Rubinstein, our public governor and host for this evening. Helena, over to you. Thank you.
Okay, thank you. Well, first of all, I want to say thank you very much to everybody for joining in and attending this evening. We've had a fantastic response. Namu tells me that it's one of the best attended that we've had. So there's a lot of people are very interested in this topic, me included. Before we get into the sort of the focus for the evening, I just wanted to just give you 2 minutes of information about what it is to be a member of Cambridge University Hospitals. I don't know how many of you who are online already are, but if you're not, do consider joining. It's free. It's open to anyone who's 16 years or over. Patients or carers or members of the public can become a member. And the reason it's interesting is for really great talks like this, but also because your opinions really help us to improve the hospital, and we really want to hear, get feedback about how you think about what's going on and what can be improved, so that the services and experiences can be better for everyone. So we'd really like you to join in. And also, one final reminder is that there's a governor's election going on. I think Monday is the last day to vote. So anybody who is a member who hasn't voted, please do, because that would be great. I think there's a couple of patient governor vacancies and one public governor vacancy. So it would be great if you could all go online and vote. And if you're not a member yet, I encourage you to find out more and join in on the website. So that's all I'm going to say about the membership and being a governor. But I do now want to get into the point of this meeting, which is that this is called the menopause transition, what to expect and how to manage it. So I'm sure you all know that menopause is a very significant phase, and people who go through it tends to be between the ages of 45 and 55. But many people don't know as much about it as they do, let's say, about menstruation or something like that. So it's very important that women get the kind of information that matters to them. So in this lecture, we're going to find out what menopause is, what its symptoms are, and how it's diagnosed and how it can be managed. So we have two fantastic speakers this evening. One is Joya Kanciani, who is a consultant gynecologist at the hospital here. She's been here since 2023, and listen, 1923, which would make you very old indeed, Joya. 2023. And she currently leads the menopause and ambulatory gynecology services, which focuses on advancing care in all these areas. She graduated at Norwich Medical School at the University of East Anglia and completed her medical training here at the East of England Deanery, and has been dedicated to women's health ever since, really. Prior to her medical career, she did her bachelor's degree in kinesiology at the University of Toronto, and that was where she really discovered how interesting women's health was. So she's going to talk to us alongside Dragana Abbott, who's a clinical nurse specialist in menopause and benign gynecology, and she's been working at CUH since 2017. And before that, she was at Hitchinbrook for 15 years in the women's health and gynecology area. So she has a wealth of experience and information to bring. She's got a real passion to think about treatment that's really individually person-centered and safe and effective. And she wants to stick to best practice and support women going through this whole transition through perimenopause and menopause. So we're going to listen to what they have to say. I think they have some slides. There's a lot of us online now, it's growing by the second. So rather than have questions afterwards, what I'm going to ask people to do is to go to the chat link. There's a chat box at the top of the screen on the left-hand side, and as you think about it, write down a question. and we will try and cover as many as we can towards the end of the session. But if we can't cover them all, we will send them on to Joya and to Dragana, and they can try and answer them afterwards. And I believe there's going to be a recording of this webinar, and that will be posted on the website, so you can look at it later. So on that note, I'm going to hand over to our speakers.
Sorry, I'm just waiting for the presentation to actually the slide. Can you see okay?
Yeah, that's great.
Lovely. Perfect. So my name is Joya Kanchani. I'm one of the consultant gynecologists here at Cambridge University Hospital, and as Helena introduced before, I'm the lead of the Menopause, and together with me today I have here Dragana Abbott. I'm the specialist menopause nurse in also doing benign gynecology, and we are together with Joya running the menopause service at Addenbrooke's. So in the next 20 minutes or so, we'll go through about what is the menopause, what are the symptoms, how we can diagnose it, what are the consequences of the menopause, how we can manage it, and we'll add for some conclusion. And then after the presentation, there will roughly about 25 minutes for some question and answers. And I just wanted to say that in this presentation, we will refer to women and females as people born at birth with XX chromosomes. So what is the menopause? The menopause, the terms comes from ancient Greek, and it means the end of the monthly cycles. So it's defined after the periods have been stopped for more than 12 months. And this is because the ovaries finish the supply of eggs. The other names for it can include the change, the climacteric, or the time of life. We know that all women are affected by the menopause. 80% have symptoms, 25% have very significant symptoms, and 10% of women actually have to leave their job because the symptoms of the menopause are so severe they are no longer able to function as they used to. And this is particularly important with some profession, such as like teachers, there tend to be many women, but also within NHS itself, the majority of the workforce tends to be female. So in order to understand the menopause, I think it's quite important to try and understand the hormones of the female reproduction. So there are three main hormones. So estrogen, which is the pink hormone at the top. I don't know if you can see me pointing. Then I have, there is progesterone, which is the red hormone here. And finally, there is testosterone, the yellow one. So estrogen is mainly produced by the ovary, but some of the estrogen is also produced by the adrenal glands and adipose tissue. It's the main hormones, as you can see here, in the first part of the menstrual cycle, and it's responsible for stimulating the follicles and then releasing an egg. Progesterone is mainly produced by the ovaries, and it's responsible for preparing the endometrium or the lining of the womb for a pregnancy. And it's the main hormone, as you can see here, which is present in the second part of the menstrual cycle. Testosterone is produced at lower levels, and you can see it tends to peak around ovulation, and that's from an evolutionary point of view because you need increased libido around the time of ovulation to then be able to procreate. So, and part of the testosterone is also produced by the adrenal glands. So throughout the stages of life, as you can see, estrogen and progesterone tends to stay quite steady until the age of 35, and then they start to decline. And when they decline, the levels start to fluctuate. So they will go up and they will go down until roughly you reach after the age of 50 when the levels remain persistently low. The testosterone level, on the other hand, it starts to decline from the age of 25. And as you can see, it goes down and then eventually it remains steady from the age of 50, but it's not as lower as estrogen and progesterone are. And if we specifically look through the different stages of life, so the perimenopause, when there was a decline, but there was the fluctuation, I want you to focus on another hormone now. So estrogen, which we talked before, is the dark green hormone. And then we have FSH, or follicular stimulating hormone, which is a hormone that is produced in the brain, and that's responsible for stimulating the eggs, the ovary to release in eggs and estrogen. So as the level of estrogen goes down around the menopause, the level of follicular stimulating hormones go up, and this is done vice versa. So one trying to stimulate and it's high enough, and then FSH goes down. But after we reach the menopause, there are no more eggs that can be stimulated by the ovaries. So the estrogen levels remain low, and the FSH, or follicular stimulating hormones, as you can see, remains high. So you can think of the menopause really as three different stages. So we have the perimenopause, which is the periods before or around the menopause. And this is when the level of estrogen starts to go up and down. So as you remember from the previous slide, you start to have a decline. And the main first symptoms that women will have is actually irregular and unpredictable periods. And this can last for several years. The menopause is actually diagnosed retrospectively after you have not had a period for more than 12 consecutive months. And in the UK, the average age is 51. And after you stopped your periods, you then enter the postmenopause, which will last for the rest of a woman's life. And then symptoms will be present for some times. They can last in between 4 to 11 years with an average of 7 years. And there can be a variation when the menopause happens. We said in the UK, the average age is 51. However, if the menopause happens before the age of 40, we call it premature ovarian insufficiency. If the menopause happens before the age of 45, we call it early menopause. If it happens after the age of 55, we actually call it late menopause. And we can also medically induce the menopause. This can be done surgically, so removing the ovaries, and this can be done, or bilateral oophorectomy, and this can be done for a variety of reasons. It can be done for a cyst, it can be done for risk reduction surgery in someone who is a high risk of ovarian cancer. And we can also give medications that can put a woman through the menopause, and this can include chemotherapy or radiotherapy. In terms of the symptoms of the menopause, we can split them into physical and psychological. So physical, and they're both mainly due to low estrogen and sometimes low testosterone. The physical symptoms, I think everyone knows probably the most common one, which are hot flashes. Hot flashes, it's a sudden onset of warmth. It usually happens in the upper part of the body, and it most often involves the face, the neck, and the chest. They usually last for anywhere in between 1 minute to 5 minutes. And the reason why women have hot flashes is because there is an area within the brain, which is called hypothalamus, which is where our body thermoregulates. And low level of estrogen tricks the bodies to think that actually the temperature in our body is too hot, and therefore you start having a hot flash to try and cool down the temperature in your body. Women might experience weight gain and fat redistribution. This is because of low level of estrogen and low level of testosterone, which will make you gain weight mainly in the upper abdomen, and in the abdomen and in the upper body. You also have, because of decreased testosterone, you have decreased muscle mass, but also women often can have psychological symptoms. So they can be anxious, they might have brain fog, loss of confidence, and when you don't feel the best, you tend to eat food that is not as healthy. Insomnia can happen for a variety of reasons. If you wake up most of the night with night sweats, you're unlikely to have a good night of sleep. But also, if you feel very anxious and you're worried about something, you will tend to wake up in the middle of the night and then struggle to go back to sleep. Low estrogen level causes the skin to be dry, and when the skin is dry, it becomes itchy. When the skin is dry in the vagina, then you end up having what we describe urogenital symptoms. So women will complain of dry, painful vagina, and that can also cause recurrent waterworks infection, urinary incontinence, and if women have a prolapse, they can worsen. Reduced libido, again, is multifactorial. It can be combination of low level of estrogen, women experiencing urogenital symptoms, but also when you feel depressed, anxious, you're less likely to want to have sexual intercourse. And finally, women might also experience joint aches, and this is more and more recognized as a symptoms of the menopause. In terms of the psychological symptoms, there are lots of different areas in our brain that actually are responsive to estrogen. So the amygdala is a part of our brain that regulates emotion, that responds to estrogen, and also the frontal cortex responds well to estrogen. So in women that have low estrogen, they will have depressed mood, they might feel anxious, they will feel irritable, they will have mood swings, brain fog, so they're unable to recall things that in the past used to recall really easily. They might feel lethargic, but if you put together all these symptoms, physical and psychological, you just start feeling losing confidence in yourself. So how do we diagnose the menopause? And we said before, it can vary between 45 and 55, which says it's a normal menopause. So in any women above the age of 45, you don't have a test to diagnose the menopause. We base that on symptoms and a history. So symptoms, as I just previously described in the previous slide. And in terms of history, if people that have a uterus will describe that as no periods for more than 12 months. In women, of course, they are not on any hormonal contraception. And in people that have had a hysterectomy while leaving the ovary behind, this is based on symptoms only. In women that are less than 45, we might want to check the level of FSH to make sure that it remains steady and high, like I showed in the previous graph, and this is usually above the level of 30 international units per liter. And if we are not certain about the diagnosis of the menopause and we might think the symptoms might be caused by something else, we might want to check the thyroid function or the prolactin level. And menopause has, of course, long-term consequences. We know that especially estrogen is responsible for lots of different health in our body. So women that go through the menopause will have increased risk of cardiovascular disease, osteoporosis, cerebrovascular accident or stroke, and also the urinary atrophic changes. And we know that because women that go through the menopause either prematurely or early, so before the age of 40 or before the age of 45, are increased risk of dying because of cardiovascular disease, osteoporosis, cognitive decline, dementia, and Parkinsonism. And actually, we know that after the age of 60, cardiovascular disease is the #1 killer in women, and osteoporosis after the age of 50 will roughly around 1 in 50% of women will break a bone because of osteoporosis with significant consequences. So what can we do about this? I'm just going to pass on to Dragana and we can try and see how we can treat the menopause.
Thank you, Joy. So we know menopause, perimenopause and menopause is part of our life, and many women choose to go through menopause and prior to the menopause with the perimenopause without asking for advice and support. However, it's very important of us to encourage women to seek at least information and advice and also provide support in our menopause service, because there are various options and information and advice and tailored plans that we can offer in order to support them best when they're going through the transitional stages of the perimenopause and the menopause. The most important, we are going to divide them. The management is non-hormonal and then hormonal with the help of the hormonal replacement therapy. And the most, first and foremost, with the non-hormonal management of the menopause is our lifestyle. So I want to stress to everybody that lifestyle choices such as eating nutritional and very varied diet, having regular exercise, reduced alcohol intake, stopping smoking, and also very good sleep is essential to have a very good menopause and transition even post-menopausally. And that's not only relevant with control of the menopausal symptoms, but in the long-term health and quality of life is important to make these very good lifestyle choices that will ultimately benefit women and their health. Now, we have also complementary therapies. There are no specific complementary therapies that are absolutely proven to yield results, but we know that it's beneficial for women with the acupuncture, having yoga, having aromatherapy, relaxation therapy. But the most important thing, which research has shown and NICE guidelines have proven, that it's actually benefiting the menopausal symptoms, in particular the anxiety and low mood, is the cognitive behavioral therapy. Now, we also know that we have non-hormonal pharmaceutical options, which are clonidine, and then we have the antidepressants, we have gabapentin and oxybutynin, and then lately is a medication called Veoza, but it's not yet licensed in the NHS because there is more research studies to be done. Now, with the second part, which has been through decades very controversial, we come with the management of the menopausal symptoms through hormonal replacement therapy. And we've had since 1965 quite a lot of data gathered on hormonal replacement therapy. And we know now with scientific research what the exact benefits are. So when we take hormonal replacement therapy, we know that the benefits only come from the estrogen component of the therapy. And the progesterone is only needed if the woman has got her womb intact, and it just protects the endometrial lining. So with the benefits, we have prevention of osteoporosis and actually aiding to the bone density. The relief of the menopausal symptoms. We know that it's very effective in reduced risk of coronary heart disease. We also know that it's got reduced risk of type 2 diabetes. And also, if the HRT started earlier, we know that there is a reduced risk of Alzheimer's disease. Now, with every therapy, especially with medication, there are certain risks. So we've got a slight increase in breast cancer diagnosis, and that's due to the estrogen receptive breast cancers. And also we've got endometrial and ovarian cancer, which could come as hyperplasia and then develop into endometrial cancer because of the stimulant effect of the estrogen in the HRT therapy. Also, we know that there is a risk of venous thromboembolism, and with that, we have bypassed that risk with using transdermal HRT in opposed to oral, because when we take oral HRT, the metabolic process goes through the liver, and also it increases the high risk of DVT, which is deep vein thrombosis. Now, we have also interesting data that if HRT is started in older women, which are women over the age of 60 for the first time, we have seen possible increase in risk, which is coronary heart disease, and or if they had pre-existing heart conditions, there is slightly increased risk. Also, in older women, older patients over the age of 60, we know that stroke risk is increased when we are taking oral HRT. Now, breast cancer, we're leading now to the first worry. What every patient in our clinic has is the risk of breast cancer. Now, the breast cancer is the most common cancer in women. So what the studies have shown is that in 1,000 women, generally, there will be 23 cases of breast cancer diagnosed in the UK, and this is the general population. Now, if you have a look at the little chart here, an additional 4 cases in women on combined hormone replacement therapy, we found that there is 4 additional cases. Now, I need to make this point, and for everybody to bear in mind, this is a study of women with the age of 50, between 50 and 59. Women who are receiving hormonal replacement therapy who have premature ovarian insufficiency, this risk does not apply up until the age of 51, which is the normal stage of the menopause. So if we move on, we can see that 4 fewer cases are diagnosed. So less than 4 women are diagnosed with breast cancer if they receive estrogen-only therapy. And the people who receive estrogen-only therapy are the ones without a womb, either surgically removed and or through many different other treatments for fibroids, heavy periods. We know that if they receive estrogen only, we have 4 less patients diagnosed with breast cancer. Now, an additional 4 cases are diagnosed on women who use combined hormonal contraceptives, which is the pill. And additional 5 cases, which is interesting, is in women who drink 2 or more units of alcohol per day. So this brings to the fore that it's very important to take alcohol intake very seriously and be within the parameters and the guidelines, or reduce the alcohol intake, especially if we're going through the perimenopause and the menopause. Now, 3 additional cases of breast cancer are diagnosed in smokers, and the biggest graph that shows how many more women have been diagnosed with breast cancer, additional 24 cases with women of BMI over 30. So healthy lifestyle, diet, nutrition, and exercise is vital, regardless of whether anybody is taking HRT or they're doing non-hormonal management of their menopause, because the biggest risk to breast cancer, and in fact any cancer, is when we're overweight and BMI over 30. Now, there are 7 fewer cases in women who take at least 2.5 hours moderate exercise per week. And this is another further evidence of how important exercise is to be incorporated in our daily life. Now we're going back to the hormonal replacement therapy, and the hormonal replacement therapy can be divided in 2 categories. We have systemic, which is like for our whole body, and then we've got topical, specifically designed for the vagina and the vulva. So Joya mentioned earlier that some of the symptoms, which can be very troubling and devastating for women, are the urogyne symptoms of the menopause and the atrophy. So all of these urogyne symptoms are directly linked with the very depletion of the estrogen when we go through perimenopause and menopause. So with the vaginal estrogen or topical estrogens, we can treat the vulval area, the labia, the clitoris, because they have loads of estrogen receptors. And often women who present into clinic, they say they're very numb, they feel the skin has changed, they don't feel how everything was before when they were younger. So this can be treated very easily with topical cream. And then the most important is to treat the vaginal dryness, because that's directly also linked with our libido. Because if sexual intercourse is painful or uncomfortable or things don't feel right, then it's very prudent to bear in mind that we can intervene with simple options like little vaginal tablets, pessaries, that are inserted into the vagina, which can revascularize the tissue and the epithelium, in which case it really plumps the cells, it brings that necessary moisture and relief of all of the symptoms, including some urogyne symptoms, which are urinary urgency or even urinary tract infections. Now, there is a slightly stronger product than the vaginal tablets, which is a vaginal ring called estradiol ring, E-string, and it's actually a very good NHS option and choice, because it requires change every 3 months rather than putting a pessary for maintenance dose twice a week. Now we're going back to the systemic hormonal replacement therapy. And now the systemic hormonal replacement therapy is divided in subcategories depending whether the patient or the woman has got a uterus or she hasn't got a uterus. If a patient has had hysterectomy, which means that there is no uterus, or they have Mirena coil, which is these days favored part of progestogen in treatment of with hormonal replacement therapy, then we only concentrate on the estrogen. So the estrogen HRT can come in a form of oral HRT or transdermal, and the transdermal can be gel patch, or we have even spray. Now, with the patients who have got a womb, it's very of utmost essence that we protect the endometrial lining with progestogen. So we combine, so this is the combined therapy of HRT, and it further divides depending on the woman. If the woman experiences still periods and she is perimenopausal, we need to give sequential therapy, which mimics our normal menstrual cycle. Or if the woman is postmenopausal, we give continuous combined, which is period-free therapy treatment, because all what we are worried is to maintain the endometrium as thin as possible in order not to stimulate it and give a problem such as endometrial hyperplasia. So all of the options can come oral or transdermal. And there are many available different preparations and different makes, and nowadays we're striving to go towards body identical HRT, which is with micronized progesterone and then estradiol. And the best delivery would be a transdermal delivery of the HRT, because it bypasses the liver and also limits the risk of deep vein thrombosis. Now we come to the final part, which is the testosterone. So testosterone is also produced by us as women, but not in such large amounts as men. But the only now difference is with the testosterone, we only it's off license, used off license in the UK, and we still need to go through the licensed bit to get it on the market. So the testosterone is used for treatment specifically of low libido or low sexual desire. There are loads of researches ongoing throughout the world. There are loads of professors and studies and showing loads of different things that they're trying to prove that testosterone helps with muscles, with bone density, with cognition, with energy. However, we haven't got substantial research done here in the UK to conclude all of these things that it's beneficial for us as women. The only thing that we have as an evidence-based research is that it helps with persistent low libido. Now we need to be mindful because we need to know that the woman is, our libido is multifactorial, first of all. So we need to know that there aren't any other causes that are contributing to low sexual desire. Also, as a healthcare professionals, we need to be aware and make sure that the women are well estrogenized on systemic HRT, because that helps massively towards how one feels towards their own libido. And then only then, after we've made sure that we've excluded many different factors, we can then concentrate in prescribing testosterone as part of a patient's HRT. And we go ahead with a trial of 3 months, and then we check the levels of testosterone and sex hormone binding globulin to get our free androgen index at the start, and that's our base level. Then we introduce the testosterone. It's either gel or a pump, and then we monitor the levels of testosterone and the sex hormone binding globulin 3 months after, and also again in another 3 months or 6 months before we discharge women to the primary care providers on well-established testosterone therapy. And once we've determined that the testosterone has provided and yielded the benefits to their libido. Conclusion, just like I started earlier, everybody at some point, all women go through the menopause, and it's a normal part of our life. Also, everyone will have some contact with an individual who is affected by the perimenopause or the menopause and who is struggling with the symptoms of the menopause. Now, it's very essential to recognize all of the symptoms and recognize what the struggle is and how it makes us feel, because this is a huge, big transition that we go through as women. And it's very essential to provide very good support, advice, information, and care to those women who are going through very troublesome menopausal symptoms. And the evidence that we have here at the moment is suggesting that it's best we start with hormonal replacement therapy or even non-hormonal methods straight away as soon as we notice that the symptoms are debilitating or affecting our quality of life. Do you have anything to add?
No, just some references back at university, not. And then thank you very much for listening. I just wanted to share, this is a link to our website, which Dragana actually kindly constructed when she started her job. And these are some very good resources. So there is the British Menopause Society that does a great job at actually controlling that the care of menopause. It's quite uniform, and it's well controlled within the UK, and they have Women's Health Concern, which is the patient sides of the BMS. So you can find lots of information, patient information leaflet, or anything that you want. So thank you very much.
Thank you.
I'm gonna stop share the presentation if that's okay.
Right, well, thank you so much. That was absolutely fascinating. We have quite a lot of questions. I'm not sure we're going to get through all of them. And some of them are very specific, so I'm going to try and alight on the ones which might have more general relevance to people. And the first one actually is an is it normal question, and I think that's quite an important thing to address, is like, what's normal. So this particular lady, Miriam, I think it is asking if it's normal to have short periods where you feel really hot for about 30 seconds to a minute with no other sweat in the evening and restless legs. So how do you define normal, and is that sort of thing normal? I don't know who who wants to take that one, but the is it normal question is quite a common one, I suspect.
Can I ask you, first of all, I think you need to put it in a context, right? So it's all about like, how old is she? Like, how are her, you mentioned she had short periods of hot flashes, or short periods in terms of menstruation?
This particular person has not mentioned what her personal situation is.
But in general, I think one important fact of the menopause, and I cannot emphasize enough, is really it has to be individualized the care. You know, we need to understand well, like, what are the past medical problems of the patient, but most importantly, how is life affected by all these symptoms, and should we do something about it? And I cannot stress enough, I think, and the importance of like a healthy lifestyle, because prevention, it's always better than cure.
Okay.
But I'm not sure I answered the question, but sometimes all I'm trying to say, different women will come with different symptoms. But you're talking about short periods of hot flashes, I'm assuming, right?
This is very short periods. This looks as though this is very short periods of what feels like a hot flash.
Yeah,
the way
to
this has
add to
been
that,
described.
There are
Yeah.
over 40 many symptoms of the menopause, over 40. There are loads and loads. The menopause affects us, the estrogen depletion affects us greatly.
yeah, Miriam has added, and just now, that
Oh,
she's
thank you.
56. She's
Yeah.
56, and it's short periods of temperature, no period for the, sorry, it's just gone up, no
Yeah.
period for the past 2 years.
Yes.
Okay, so it will be a hot flash. There is a wide variety into how long hot flashes last for, and some women will have them more frequent, lasting shorter, and other women will have a hot flash that can last up to like 5 minutes or more. And again, for her, if it's debilitating, she should go and see someone, and then potentially discuss how she can manage that. Thank you.
Miriam, I hope that answers your question. Here's there's another question here, which is a kind of general one, which is somebody saying myalgia is more common in women over the age of 40 or 40 to 50s. Is there a link with menopause?
We know more and more that there is a syndrome of the menopause related to low estrogen and joint ache, muscle ache, and those are also symptoms that women will experience with fibromyalgia. So in that situation, potentially fibromyalgia can get worse. If someone has it before the menopause, it might become worse. So sometimes, if there are no contraindication and a woman wants to, a trial of HRT in that situation, depending how much is affecting the quality of life, could potentially help.
I just need to mention that the symptoms of the menopause also overlap many different illnesses. So it's very vital to diagnose everything correctly, and also have like a very good blood assay that we test even like vitamin D, B12, folate, ferritin. We do full blood count. We check HbA1c indicator for diabetes. We check full lipid profile, and holistically, we look at each and every individual in a very, very specific individualized manner in order to determine what's the best advice that we can provide as health professionals in order to equip them to make their own informed choices in their care.
Thank you. So Mary's asking a question about what she describes as natural medicines to improve symptoms. So she said she has symptoms of insomnia and brain fog. She's taking lion's mane and ashwagandha to help with those symptoms because she can't go on HRT. She's also been told she has high blood pressure, which is unusual for her. And she wants to know if there's any other natural medicine to improve symptoms and regulate the cycle.
Can I take? Yeah, go for it. So with scientific research and all our nice guidelines in British Menopause Society, we do not recommend any alternative or any other herbal remedies that are there on the market, because we do not know the regulators, we do not know the quality and the quantity of what they're advertising. And there are loads of companies and loads of people out there that they will try to sell anything and everything in order to say that it improves the symptoms of the menopause, but there is no valid evidence that it does. And it's very dangerous actually to take loads of different things that you believe will help with the menopausal symptoms, because you don't know what it is in that particular thing. And there is nothing evidence-based to back this up, and in fact it can be dangerous. The only best thing, if you can't take hormonal replacement therapy because of cancer risk, just to mention, hypertension, high blood pressure is not a contraindication for you not to take HRT. So the only non-hormonal things what we need to concentrate on is good nutrition. But also with good nutrition, it comes taking very good vitamin and supplement preparation. And in fact, if we take magnesium glycinate at night, which is magnesium, which is a mineral, it can actually improve our sleep and produce better sleep quality. And it's safe, it's regulated. The multivitamins and minerals are regulated in this country. I absolutely advise everybody not to buy anything that's specifically targeted for menopause, and it's under the pretense of bioidentical hormones, which is no such thing, or other herbal extracts that are claiming that will give menopausal symptoms relief.
Thank you for that very complete answer. I'm just looking for the question that kind of followed on from that. Hang on one moment. I'd actually alighted on it and now I've lost it. My computer has just decided to stop.
Would you like me to
I've lost what I was about to say, so I shall
Okay.
just carry on. So here we are. There was a question about other alternative. There's been quite a lot of questions about alternatives to HRT, which you've partly answered, and there's been quite a lot about that. But somebody here specifically, this is what it was. So there's somebody here who says that in their family, there's cases of breast cancer and ovarian cancer on the maternal side and the paternal side. And her relatives have had cancer at menopause age. Is there any benefit, she asks, of doing HRT to prevent cancer, or does that just add to the risks?
No, HRT will add to the risk in general. But may I suggest for this person, if there is a very strong family history of breast cancer, I think like Probably, I'm not sure if a genetic mutation has been found within the family, but here I think we're very lucky at Cambridge because we have a very good clinical geneticist service. So if there is a strong family history of breast cancer, the GP can do a referral to the clinical geneticist to try and see if there is found out of a link. I wouldn't go in general, the advice in that situation. Of course, we will have to see you. These are the patients that we will see in clinic, and they will often be seen by consultants because of all the risks. And in general, it's a discussion about risks and benefits. But I would think of like actually HRT making things potentially increases the risk of cancer.
Thank you. So Wendy's asking a question about is there a link to high cholesterol in women who are postmenopausal who are not on HRT but have chosen to follow a healthy lifestyle approach?
I mean, we all know that estrogen is responsible, for like our endothelium, right? And to decrease the risk of developing atherosclerosis. And that's why, if you look before the age of 50, roughly, men have a significant higher risk of dying from cardiovascular disease compared to women. And women very nicely catch up and then do better than men, unfortunately, after the menopause because of the lack in estrogen. So as I cannot stress enough, like we all know, healthy lifestyle, follow the Mediterranean lifestyle. I'm partial because I come from Italy. Exercise, that will all help. But in that situation, if you have symptoms of the menopause, and you're doing, I wouldn't go on HRT just to prevent that. Let me put it clear, because there are other things. If you're just going to prevent atherosclerosis, you should probably be on statin and aspirin and other medications that are done by cardiology or by GP. But HRT can help. It started early on in life. So if I can give an advice, if you want to start HRT, it's always better to start it early on rather than later.
Okay. So I'm wondering if you can give Virginia some advice. Actually, she said that she's 43 and has a lot of perimenopausal symptoms, mainly brain fog, hot flushes, fatigue. She's asked her GP, who said, "I'm too young to be perimenopausal, and she's not entitled to HRT. What should she do?"
So my first question to her will be, how are your periods? Because if your periods are starting to become slightly irregular and you have all these symptoms, you actually will qualify for a trial of HRT. And because you're still having periods, if we go back to the diagram that I was showing where the hormones are going all over, there is actually no point in testing your hormones, because at some point I might catch the FSH high and another point I might catch it low.
It fluctuates. So although we say we need to check the hormonal status of women below the age of 45, still even a normal FSH and LH, and the woman is suffering with troublesome menopausal symptoms, that indicates that that same woman is actually going through perimenopause where the hormones fluctuate. And then at some point, she will have depletion of estrogen, which brings on the menopausal symptoms. And it's wise to trial her on a nice, very low dose cyclical regime of HRT to help.
I hope that helps. I think it's quite common for women to be dismissed, so keep asking.
Unfortunately.
Yeah. Somebody here, Kathy's talking about bone health specifically. She wants to know whether HRT always helps with bone density, or are there some women where bone density actually gets worse despite HRT and optimizing lifestyle. This person has osteopenia and has had DEXA scans that show that this has got worse despite being on HRT, walking, taking vitamin D, etc., etc. So how does HRT impact?
I'm not sure how old is she.
I'm afraid that Kathy doesn't tell us.
That's okay, but so all I wanted to say, so HRT is probably one of the only treatment in terms of osteopenia, osteoporosis that can actually help rebuild bone mineral density. And the evidence show that it does that at the spine and at the hip. So we have grade A evidence for that. However, the HRT needs to be well absorbed, and we know from research that you roughly need to have a level of above 250 picomoles per liter to be able to have the benefits of HRT. So I think things needs to be explored a little bit more for her in terms of like which HRT she on, is she on the right dose, is she taking it properly, if she's using a patch,
Yes.
is it sticking well, if she's using a gel, is the gel being absorbed well.
Okay, I think we've got time for one last question, which is about achy joints. A 55-year-old who's suffering with left knee pain and has had no period for 18 months. Is it normal to have very achy joints?
Yes. Almost all women who come into my clinic, they all have achy joints. And then once we tailor the perfect hormonal replacement therapy for them, almost in all of the patients, we see great improvement, especially with the joints. So the low estrogen and especially going through the menopause will naturally bring all of these symptoms. And like we said earlier, there are over 40 symptoms of the menopause, and achy joints and pains and aches, especially morning when waking up and feeling very stiff and not able to actually mobilize or be like ready to go. That's very, very classical symptom of the menopause, and using HRT will help. Also, very good diet, multivitamins and minerals.
I think we probably have come to the end because we've only got a minute left. So it's been absolutely fantastic. Those of you, there's many more questions. So I'm going to pass them on to Joya and Dragana because there's no way we can get through to some of the detail that I think people are asking about here. So I just want to end by saying to everybody, thank you so much for attending. It's been really interesting. Your questions have been absolutely fantastic. There is a little survey which I think Namu is going to put a link to on this chat area. So we really appreciate it if you would fill it in and just tell us how things were. And you will get notification of the webinar, a link, so that you can look at it and look at the detail a bit later, because I think there was a huge amount of information to take in. And I mean, this is my area of, I did my PhD in this area, and I had a few things that I thought, oh, I didn't know that. So that was really great. So thank you very much indeed. We really appreciate it. And please remember to fill in the little survey if you have time. Thank you very much indeed.
Thank you, everybody.
That was great. Thank you so much, everyone. Have a good evening. Bye.
Thank you. Have a lovely evening. Bye-bye.
Bye.